Well, let's dive into this last of four part sessions where we've been doing deep dives into the Radar Implementation Strength Assessment and Quality of Care tools. My name is Jessica Ferne. I'm the Director of Global Health Impact here at CanWaCH. And it's been really interesting to follow this progression of analysis into the ISA and QOC tools. And we're finishing up today with this opportunity to really focus on the nutrition counseling piece. And I hope to get some good insights from folks here, as well as from our colleagues at Radar about where we're at kind of with these particular tools and where we go forward from here. So a huge thank you to everybody who has been along for the journey with giving feedback and insight onto these tools. It will be great to talk a little bit more at the end of this session about where we go from here. So some quick overviews before we dive in. Most of you have heard this many times by now. Myself and my colleague at MIN are here to provide any technical support that you might need. You can write to us directly in the chat and we'll be happy to help you out if you're having any technical issues. We are a group, today we'll be doing some smaller breakout sessions if possible. And so we encourage you to come off mute and ask your questions out loud, or of course you can write them in the chat and we'll try to speak them out loud to make sure that they're documented and we get to those. All of these sessions will be recorded. Since this is the last in the series of sessions, we'll be editing the videos just for clarity and for easy navigation and making them available, all four of the deep dive sessions plus the orientation session that we did on July 20th. And we'll be making those available on our CanWaCH website, as well as sharing them with the JHU folks who will share them on the site with the tools as well, so that you'll be able to pass these on to your colleagues or refer back to them at any point in time that you would like to. So we'll be posting in the chat, but again, please visit isaqocfeedback.com, enter the password radar 2020, and when you do so, you'll be able to see all of the tools and resources there that we'll refer to. And with that, I will turn it over to our colleague Emily from JHU to take us through the introduction and go on from there. Emily, over to you.
Thanks, Jessica. I'll just let Melissa share her screen with the presentation. So as Jessica said, this is our last in a series of webinars. I know some of you have been with us for all of them, and some of you have been with us for a few, or this might be your first one. So we'd love to first introduce our team who's on the webinar here today, and then have some introductions from you as well. So I'll start. My name is Emily Frost. I'm a research associate at Johns Hopkins University, and I've been working on the Radar team on the implementation strength assessment and quality of care evaluations for about 2.5 years. Melissa?
Hi, sorry, I couldn't find the unmute button while I was sharing. I'm Melissa Marx. I am the PI of the Radar ISA QOC team, and I'm an infectious disease epidemiologist and evaluation specialist, and have been happy to work with this team for the past 5 years.
Thanks. Diwakar?
Hi, my name is Diwakar Mohan. I'm an assistant scientist at the Johns Hopkins Bloomberg School of Public Health. I'm one of the technical leads on the implementation strength and quality of care assessment tools, along with Melissa and Emily. Nice to be here with all of you.
Thanks. Cynthia?
Hi, everyone. My name is Cynthia. I'm now a second-year MS-PhD student in Johns Hopkins School of Public Health. and a student as research assistant in the team. Thank you.
Thanks. So now I'd like to have our participants, if you could say your name, the organization you work for, and if you've had any experiences implementing any evaluations, specifically any implementation strength or quality of care studies, and what your experiences are with that, and also your expectations for the radar tools and what you hope to get out of this webinar. So we can start with Juliana.
Yes, hi, I'm not on mute, I'm not. Thank you, pleasure to be with you, learning a lot out of this series. I've never had a chance to implement anything related with ISA, Implementation Strength Assessment. I am an evaluation advisor for the Canadian Red Cross in international operations. We have some experience, I have some experience implementing radar tools, coverage survey and others for South Sudan. But this angle of the ISA, it's new. I'm still learning. So thank you for having me and for coordinating this session. Thanks.
Thanks, Juliana. I see Lue is on as well. Lue.
Hi, I'm advisor with the Canadian Red Cross on project planning, monitoring, and evaluation. I've been the focal point with radar on implementing the ICCM, quality of care and implementation strength in Mali. And I've been learning a lot from the series on the other tools and look forward for today's session. I had the chance to go through the data collection tools and look forward for your presentation. Thank you.
Thanks. Asrat?
Hello, everyone. Thank you so much. My name is Asrat Dibaba. I work for World Vision Canada as a chief of party for maternal, newborn, and child health program, which we are implementing in 4 countries, Tanzania, Kenya, Bangladesh, and Myanmar. Our program is funded by Global Affairs Canada. We have been implementing this program for the past 4 years. We have 1.5 years to go, and we do a lot of health system strengthening to improve especially quality of care. We do health facility assessments and including supply chain and health management information system, etc. So it's very useful for me to be in this series. I have had a chance to participate one so far. Thank you.
Thank you. We did have someone else here, but I don't see that person anymore. So why don't we continue on with the next section, which I believe Diwakar will lead.
Thank you all for coming. And I know it's the same crowd. We have Asrat, Juliana, and Lue from yesterday as well. So you probably have heard some of these slides before, and you've definitely participated and contributed to this based on our objectives. So today's session is going to be slightly different from what we did yesterday because of the nature of the kind of program that it is and the type of tools that we are trying to present here. So we will start with initially presenting some of the methods and tools that we have used for the evaluation of nutritional counseling. We want to prompt discussion about the strengths and weaknesses of the tools for the different evaluations. And primarily, we want to solicit ideas for how to measure these in alternative ways, how to measure the objectives, the indicators that we want to focus on in different ways. And we also want to finish up with giving you information about how to access the tool so that you will be available to provide us additional inputs after this webinar. So if you notice the agenda, we have a slight difference in based on what we did yesterday. Like after Melissa initially presents about the tools, we will intend to kind of do it like a group work and kind of almost as if we were trying to brainstorm different ideas for some of these tools before we close. Melissa, can you move on to the next slide? Yep. So quickly orienting you to the tools, we've already covered interpretive tools in Tanzania, child health in Malawi, child health in Mali, and family planning in Malawi. Today, we're going to be focusing on nutrition counseling, specifically of pregnancy and postpartum women, and we had the opportunity to test this out in Mozambique. And again, the goals are very similar to what we've seen before. We want to identify strengths and gaps to kind of provide information on improvements in program implementation and policy, and primarily to see whether the program that we planned can provide care at a level that's high enough for us to make an impact. And these are especially valuable in trying to support some of our findings at the end, like trying to explain why and why not we achieved some of the impact goals that we set out to achieve as part of the program. So again, the quality of care, it's the degree to which health services increase the likelihood of health outcomes are consistent with current professional knowledge. And these are the common domains that we have actually looked at for implementation strength. And we continue to use the same domains throughout these programs as well, like availability and accessibility, infrastructure, commodities, and personnel. Melissa. And again, we want to frame it in the context of our impact model. Basically, we are focusing on question number 2. Is the program being implemented at sufficient strength to achieve the expected services? And are the services being utilized by the target population? And the third question, which is, are they being delivered at a high enough quality to achieve the impact that we set out to achieve? Next slide, please. So again, the decisions on what tool to use, these will depend on some of our objectives for the evaluation. So primarily the tools that we have used here are ones for implementation strength, which include provider interviews and assessment of supplies and equipment. Then the others, which include measuring provider technical performance, like direct observations, record reviews, simulated clients, interviews and vignettes, and patient exit interviews. So what do we need to consider? We continue to look at the goals. What do we need to strengthen? Policy, program, and strengthening evaluations. What specific questions are we trying to answer? Is there something of very importance to this specific program that we want to consider when we design the program? And the other considerations include, what are the risks? How much do you lose if you get it wrong? What's the risk versus benefit? And finally, one of the most important questions of all, your availability of funds, resources, and time. So I'll hand back to Melissa for managing today's session. On to you, Melissa.
Thank you. I'm challenged to mute and unmute while I'm sharing screens. So a little small thing that I'm learning here. So, sorry. Can you guys still see my screen? Maybe you can see the whole thing. Okay. Come back to this one, excuse me. So we evaluated part of a program called SANI in Mozambique. This was a program that was being conducted in several other countries. And I actually need to read my notes here to have the details about the countries. So 1 second while I pull this up on another screen so that you can see it here. I thought I'd be able to see. Okay, so SANI stands for the Southern African. Excuse me 1 second again, apologies. I don't know if Zoom is making my computer glitchy or what? That's a little...
Southern African Nutrition Initiative.
Yeah, sorry, I can do it. I'm just trying to, okay. So it's called the Southern African Nutrition Initiative, and it's in Mozambique. It's being implemented. It's still being implemented in Hambane province, in Hamwine and Funaloro districts by CARE. And they began implementation in 2016 and they continue now. The goal of the program is to improve nutritional status and overall health of women of reproductive age and children under 5. For the program, train community health volunteers, deliver home-based nutrition counseling to pregnant and postpartum women who are thought to be at high risk for malnutrition. Basically, they're women, families that are selected at the local level because local leaders thought that they could benefit from this program. The sessions that are being conducted focus on nutrition, dietary diversity, breastfeeding, complementary feeding practices, as well as nutrition sensitive topics. And basically, the CHVs refer any severely nourished children to one of 10 health facilities for care, but it's a passive referral. So they suggest that they go to the health facilities, but they don't facilitate it. So when we signed on to work on this evaluation, we understood that the SANI program was much more comprehensive than just this community health worker program, although this was an important part of it. And we were trying to decide, what made the most sense for evaluation. We felt like referrals to the health facility where the beneficiaries could get treatment for malnutrition was really important. But since it wasn't a facilitated referral, and since the health facilities didn't keep track of whether and which children were coming from these referrals, okay, the only slide I'm talking about is still this evaluation of the SANI program. Can you guys see this still?
Yeah, we're seeing the image with the map and the two people.
Yeah, that's fine. That's what I'm hoping to show you right now because I can't look at my notes at the same time. Can you guys see that now?
Yes, we can. Okay,
apologies. So I was just saying that, a decision point for us and a decision point for evaluators is really what part of the program needs to be evaluated and what would be the results of an evaluation. What are actionable results for an evaluation like this? And as I was starting to say, we felt like referral was really important because that's where kids with malnutrition would actually get supplemental feeding and treatment for malnutrition. But since it wasn't an integral part of the program, our collaborators were interested in hearing specifically about how the program was working against how they designed it, which is a really important, part of program evaluation. We added on this component of seeing if the facilities to which these community health workers would be referring people had the capacity to accept referrals and to actually provide services because we thought that it made for a richer evaluation. And we felt like without that, the program would be missing an important component. So just to point out, as an evaluator, you have to make some of these decisions about, do I jump into this and which parts are important to evaluate, and is there something that needs to be evaluated that would be along this impact chain that we're not planning to evaluate, and an evaluator needs to work with a program to sort of figure out what the scope is of an evaluation. So that was an early discussion point for us, and yeah, and you'll see some of the results of that discussion. Sorry again that I'm showing you this view. It's I think that's the last one actually that I wanted to look at some notes. I didn't want to crowd you with all that other information. So the goals and evaluations of this, the goals and objectives of the evaluation itself were to identify strengths and weaknesses in their counseling program and in government facilities where beneficiaries who were diagnosed with malnutrition would be referred for care to improve counseling and care of referred children. So specific objectives were to assess the strength of implementation of the nutrition counseling aspects of CARE's SANI program in Mozambique, assess the readiness of health facilities to provide appropriate treatment when they got a referral, and assess the quality of nutrition counseling provided by the community health volunteers who were implementing the counseling program that SANI, within SANI. So the methods were, it was a cross-sectional and observational study where we had really two different arms. One was this health facility assessment and one was the CHV counseling session. And these tools were developed for the CHV counseling session very specifically to see if the messages that SANI program put together were being conveyed in the way that they were supposed to be conveyed. They were, the community health volunteers understood them first. They were conveyed appropriately second. And then thirdly, the recipients actually understood what they were being told and remembered them correctly. We also, and those are the three, I don't know if you can see my cursor, but these are the three tools here: the knowledge assessment, the counseling observation, the beneficiary exit interview. The CHV interview was a way to really understand the community health volunteer and their background and information about them that would be important to consider when seeing whether they were equipped with what they needed to have during their counseling session, and then whether they had the basic education and competencies, and they were being supervised and trained the way that the program thought they needed to be to actually execute the program. Second half, as I mentioned, was the facility assessment. We did an implementation strength assessment only with the facility, looking at talking to in-charge nurses about their supplies and commodities, and then we did, and their staffing and their supervision and oversight. And then we talked to nutrition providers in the facilities to figure out if they, they were competent to provide the services, not whether we didn't do an observation, as I said, or any kind of simulated client with them, just because they weren't part of the SANI project. And we had agreed with the SANI program that most of our evaluation would focus on the SANI project. So for this project, the CHVs were informed by CARE by phone that we would be visiting them on a certain day, and the health facilities were informed by the Ministry of Health through INS, in English, the National Institute of Health of Mozambique, that was our collaborator in the evaluation. So the next thing, maybe I'll stop there just for a second. The next thing I intend to do is go through and show you the tools. And I'm really gonna focus, because I think the facility assessment tool and the provider interview for the facility are quite straightforward. I'd really like to focus on the community health volunteer tools, because we feel like we struggled with the way to get at nutrition counseling in a way that, number one, was easy to analyze, number two, was useful for the program, and number 3 was consistent with sort of overall nutrition program knowledge that expands beyond Mozambique, expands beyond this program. So I'd be happy to go through the facility assessment and the facility nutrition provider interview if you'd like. But after I ask for questions, I'm going to jump into those tools. I'll pause now and see if anybody has any questions. Anything in the chat box? Okay.
I think considering that we have just 3 external participants, please feel free to kind of raise your hand and just speak up as well, even without the option of typing into the chat box.
Yeah, great. Okay, so I think all 3 of you have been in these sessions before, so you're familiar with the isaqscfeedback.com link, and the password is radar 2020. I would invite you actually to jump into that. I think I need to change how I'm sharing. See how I do that. 1 second. Let me see how I change out what I'm sharing. Okay. Gotta unshare first, I believe. Yep. And then I'm gonna reshare here from the website. I'm kind of on the old side, so sometimes it takes me a little while to get all these things right. The Finder, let's see. Chrome, that's probably it. Okay, can you guys see my?
Yes, we can.
Yeah, great. Okay. All right, so feel free to go there yourself. And I'm sure that Jessica shared the link. We're going to go up to pregnancy and postpartum counseling. And I know you guys have seen all these other sites already too. Just like the other links that we've gone through in the other sessions, we have the different parts here. The tools are here in part 2. Let's see, the evaluation report. Okay, so I'll point out first that these are the tools I was talking about. Again, we're gonna really focus on 1 through 4 here. And then when we break out, you're welcome to look at all of them, but we're actually gonna request that you focus on either 2, 3, or 4 in the little breakout rooms. The research protocol that we used is linked here, and this evaluation report is in draft form, and so we have it here just for our use during this webinar. We'll replace it with a final evaluation report after our partners have finalized it, which should be any day now. But you may see this disappear after this webinar if you come back, because I asked Emily to put it up just for this purpose. Okay, so I'm going to start with a community health volunteer questionnaire, which is somewhat straightforward. I'm going to go through it real quick. I'm not in the fastest internet world right now. Sorry about that. Yikes, sorry for I guess this is home computing for you.
And sometimes it can be a little bit slower when you're sharing your screen and loading it. So if need be, you can take it off share, see if that makes a difference, and then reshare as well.
Yeah, you're right. Okay. I'm also going to pull up, I yeah, I'll start with this one. Okay, so you'll see throughout this document that I've put a few questions in the margin, and we don't have to go through these now, but if you have a chance to look through these questions and give your thoughts, this is it would be really great for us to see. So this questionnaire really gets at demographics of the community health volunteer who were residents of the communities. It gets at demographics, literacy. There was not a requirement for literacy among the community health volunteers, and we implemented the survey in Chitswa, which is a local language. I hope I'm pronouncing that right. But that is not a language that people read. It's not a language that normally people write down or read. So the sentence that we asked them to read was written in Portuguese. So this is a concern and a problem that we discussed on one of the other webinars as well, but it's something that you guys might want to discuss in your breakout rooms.
Can I just jump in for 1 second?
Please.
Melissa, I want to, and I think that this is probably common among programs, that the local language is usually maybe not written, but all of the training materials for CHWs or CHVs, all of the job aids they have are in a written language. So in this case, Portuguese, all of the standing materials that the CHVs used were in Portuguese. And so we had the literacy phrase in Portuguese specifically to see their literacy in Portuguese for that reason.
Thanks, that's a really good point, Emily. I mean, there's an inherent challenge when you don't have a written language and you need to have materials for people to use, and an inherent problem when people aren't literate and you want them to use written materials. However, I should also say, to add to what Emily said, that a lot of the materials are also have they're pictorial. So a lot of the materials that the project used included pictures to illustrate what the community health volunteers were supposed to say. So we tried to get at how long they had been working as a community health worker, were they from the village, and did they go to school, what was their education and marital status, what training did they receive, how long ago it was, and what topics were included in the training, how many supervisions they have had recently, and when the last one was, and who was it who supervised them. And I don't recall why we cared whether this person was male or female, other than the fact that there are gender sensitivities in rural Mozambique. Do you guys remember that, Diwakar or Emily?
Yes, one thing that influenced us was our recent experience in Mali as well. Like in Mali, we felt that maybe when there are male supervisors, the female CHWs may not have the kind of option to kind of open up and discuss some things and assert themselves, probably. So we wanted to make sure that we captured if such kind of gender differences did exist.
And Thanks. It's important to note here too, in this program, all of the CHVs were female.
But the supervisors were kind of a mix of male and female. Actually, many were more were male than female.
Yeah, thank you so much. So then we really went down and sorry, we looked down to see what they had, what the supervision actually was, whether their supervisors observed their counseling session, gave feedback, and we found, Louis may have some feedback on this, we found in some of our other ISAs that it seemed important for feedback to be given to the person that was receiving supervision. So we thought it was important to try to pull that out. So service availability, it's really utilization and availability of their services, how many clients did they have, and checking their tracking sheets, how many of them were the different categories of beneficiaries, which were pregnant women, postpartum women just after birth, and postpartum women from 6 to 12 months after birth, and which was the duration of this program. And then what demand generation activities they did, which is not a traditional part of structural quality in the Donavidian framework, but this is what an important part of implementation strength assessment for us, really understanding what they've done to try and get people interested in participating in a program like this. And then we did this, the materials were few that the community health volunteers needed to have, but we went through all the materials that the CARE program told us that they should have. Here's the literacy question. Sorry, I brought it up way beforehand. So that's the first tool that I wanted to tell you about. Quite straightforward, and we're not going to have a group focus on this in the breakout. So in a moment, maybe if there are any comments, maybe I'll open it up for comments while I'm pulling up the other form, knowing that they take a little while to bring up.
One word about the literacy question. We received the feedback from the data collectors in our Mali implementation that the CHWs in that case were really, really nervous when they were given the literacy question. And so we put it actually at the end of the ISA in the Mozambique implementation to hopefully have it at a time when the CHVs were feeling more familiar with the data collectors and could hopefully be a little bit more at ease.
Just want to ask one question. I see they are called CHVs in Mozambique, not community health workers. So what's the implication on that when they say community health workers? And if you could also share whether, how they are motivated. Are they part of the public health system? Is there any remuneration paid to these CHVs? Maybe if you could share something around that, the community health system structure in Mozambique, so that we can fully understand, how they are supervised, the reporting structure, and etc. One question to Melissa. I think at the beginning you said for this evaluation, you worked with the implementers, probably planning the evaluation and executing also the evaluation with implementers. Can we consider this evaluation as developmental evaluation? Because I think it probably doesn't qualify to the formative and the summative evaluations, which we know. Can this be considered as developmental evaluation? Because the overall goal is to improve implementation and result, and you had planned together the evaluation and executed it together with the implementers. Thank you.
Thanks, Asra, for those good questions. And let me handle the first one, and then I'll just pass it back to Emily and or Diwakar for I'm going to handle the second one and ask them to handle the first one. So we worked with the implementer to understand the program, which we feel like is a very important part of ensuring that the evaluation is really getting at what the program is trying to do. We do this in all of our evaluations. We do not work with the program implementers to actually collect the data. They will introduce us to gatekeepers that allow us access to people who are implementing the program. Like I said, they're the ones who helped us set up appointments with the community health volunteers, but they weren't part of data collection at all. So as far as independence, I would call it an independent evaluation. As far as summative, versus something else like formative. Our implementation strength assessments are typically done after the program has started. Usually we try to give the program a chance to have these workers firmly in place and trained and have some experience, so we can check out what their sort of optimum operational capacity is, and structural, if they have what they need to do their work. So it is not an impact. We're not getting impact out of these evaluations, these implementation strength and quality of care assessments. We're getting an interim look at the strength of the program and whether it is even set up and operating in a way that can lead to increases in coverage and quality coverage, and whether that therefore can lead to impact. So that's why we showed that impact model. So it is different from an outcome assessment or an impact assessment. This is really process and output.
And I just wanted to add that we are trying to kind of move towards the developmental evaluation methodology, because we see that when we do a completely independent third-party evaluation, sometimes the results are not very well received. And we feel that involving and making sure that we understand the concerns of the implementer and kind of engaging with them and creating a good working relationship right from the start is kind of very key to the evaluation results being taken up. Unfortunately, we have had previous experience where some of our evaluation findings were kind of rejected outright, or their credibility was questioned for various reasons, because they did not exactly show what was favorable to the implementer. In a way, I would say we are trying to kind of move towards a developmental approach towards evaluation. And ours was more of a normative evaluation. We came somewhere in the middle of the program. We were neither at the end nor at the beginning. And so rather than formative or summative, we would probably call ourselves a normative evaluation, just making sure that the program fidelity and implementation strength were kind of what was planned as part of by the implementers.
Thank you. That's very helpful.
Just to answer your first question, Asrat, the CHV versus CHW distinction was something that the program care, that was just the names that they used. And so that is why we adopted those names. They were not part of the official health system in Mozambique. So in the health system, I believe the care program was originally looking at working with what are called in Portuguese APs, which stands for something in Portuguese, I don't know, but it's probably close to a community health worker. And they ended up not being able to work with the APs due to them just already having a very large workload and being community volunteers. And so they recruited program-specific CHVs from communities to work on their program. They were, I believe, paid a small fee. I don't know more detail than that about their payment, but they specifically worked with the SAMI program. I hope that answers your question.
Thank you, Emily. Yes, that answers my question.
So are there any other questions? I want you guys to keep that ISA QOC website open, but for the sake of time, I think I'm gonna resort to a few slides to summarize the other forms, because you'll jump into the breakout rooms in a moment to go through them more comprehensively. But any other questions before I jump back in? Okay, so the second form is CHV knowledge interview. And as I said before, the job aids that were given to the community health volunteers were quite specific. They talked about what foods that are recommended, what foods are to be avoided, what breastfeeding advice is for the various ages, as well as supplemental feeding as the baby gets older. They talk about hygiene and family planning and antenatal visit services. And so our tool goes through to see if the community health volunteer recalls all of those things. You'll see here I've excerpted a small subset of the questions here, and you can see that we ask questions like, what food should a pregnant woman eat? And the community health volunteer needs to mention these foods. And this is like, you know, what they mention, we say yes. What they don't mention, we say no. And then we go through and say, what should a pregnant woman not eat? And these are, as I said, directly taken from the SANI materials. So it's a test of their knowledge, but also of their recall of the SANI materials. And then we go through that for each of these topics in the knowledge interview. And when we break out in a moment, I'll ask you guys to, you know, peruse this and see, but this is the format of those knowledge interview questions. So form 3 is the counseling observation. And the counseling observation, I think all of you were on the may have been on the interpartum evaluation, and I think some of you guys were on the ICCM and some on the family planning. It was the same type of format where we kind of go through a tool that people use to sort of look to see in the order we think that it'll probably happen, but the data collector did need to move around within the tool in case the CHV talked about something in a different order than we just guessed that they might. So the topics covered here were documenting the experience during the counseling session, whether the counseling information given was accurate, and whether the volunteer was actually respectful in her interactions. And again, we look, this is all from the guide that CARE gave the CHVs, that many of them used to guide them in the actual counseling session. As an aside, and I think Diwakar can talk about this in this session, we did use audio-visual recording of interviews to see what the difference is in accuracy of reporting from the paper pencil version. And we had non-nutritional experts review and experts review, but that analysis is still in progress. And that was sort of a side analytical project that we had we didn't think was going to help us to understand the best way to evaluate, but wasn't necessarily going to help the program to improve their care. Finally, the beneficiary exit interview. Emily will talk about this in her breakout room. We gather information about the beneficiary, usually the pregnant woman, or the woman with the baby who just gave birth. We understand the demographics, the household situation. We get information about whether they understood the topics covered during counseling and could regurgitate them. They could tell us what the CHV said and to determine their accuracy and whether they covered the topics they were supposed to have. We did have a satisfaction assessment. How satisfied were they with their care? And Emily will talk about this with her group. and it was this satisfaction assessment was really based on some formative work that was, some qualitative work that was done beforehand to understand the best way to get at satisfaction in this population for this subject. So I'm gonna stop there, and I'm gonna stop sharing this, and I'm gonna go back to this, this tool tour presentation. And what I'd like to do next is talk about the fact that we did not love these tools. We did not love the 3 tools that I focused on just now. We had some difficulty. It was difficult to identify what were correct and what were incorrect responses, because some of the responses that were included were meant to be incorrect and were meant to be neutral, but we did not identify those ahead of time. So we had to go back and work with the care folks to identify which of the responses was, absolutely wrong, a little bit wrong, neutral, and how many of those did they need to get right to say that they understood the topic, or that they counseled properly on the topic. So we found it a little bit harder to analyze than we liked, than we wanted. We also planned, because that was challenging, we planned to do a comparison of the knowledge of the CHV to the practice of implementing the counseling session, to the knowledge of the beneficiary. And that was difficult to do because of all the steps that we had to take to determine whether they got it right or not. So we don't anymore think that this is the optimum way to do this. And we wanted to talk through in the breakout groups what you think about the tools and what are the strengths and weaknesses. And we wanted you to talk about the challenges of capturing these kinds of data. First of all, is it the right thing to do to adhere directly to the materials that the NGO or whoever is developing the program is giving the participants? Because if you want to know about impact down the line, you want to know if they're giving correct information, not necessarily if they're giving information that's has fidelity to the materials that they were trained on. So had a little bit of an existential crisis around that, and we'd love for you guys to discuss it with us and your colleagues in the breakout rooms. If there are other ways that you would suggest capturing the data, and ways to alter the tools so that they can easily be adapted for other settings. So as I said, these tools were developed based on the SANI materials. And so to adapt them to other settings, which was our raison d'etre for radar, you would just have to look at your materials for another program, or you would want to think about broadly what are correct nutritional messages to determine whether these whether the program implementation would lead to impact. And the other challenge there, of course, is that different settings may have different availability of foods and different cultural aspects that lead to choosing different nutritional, different ways to meet nutritional goals. So all of that is something that we haven't talked about in our other tool sessions, because we liked those other tools and we felt like they worked well for us. There are some things that our partner got out of the evaluation we did here, and they're making changes to their program accordingly. So it wasn't a total wash. We just would love to hear what you think. And so the plan for us is that Jessica and Imayan will be kind of arbitrarily assigning you to a room where you'll look at this the tool website. You can go through your own tool tour, but we're going to ask you guys to focus on one of the tools to identify strengths and weaknesses and discuss these thoughts, and then bring back your thoughts and answers to the larger group for discussion. There's the whiteboard that's available for this, that your facilitator, you'll have somebody from Radar in each of your rooms. So let me stop there and see if there are any questions about what we're going to do next.
Melissa, thank you. I have a question. When I looked at the tools, I didn't see anything that raised the red flag for me. So I'm not sure why it wasn't that helpful, because they seem to be normal questions, especially if the answers were taken from the manuals, the training manuals.
Yeah, I mean, I guess for us, we just felt like it's a little bit arbitrary to determine whether the program was meeting the needs for high quality nutrition evaluation, counseling evaluation, and we felt like just ticking off topics that the program wanted to convey, we didn't feel necessarily satisfied with that. So let me ask if Diwakar or Emily wants to add something to our feeling about our tools.
My thoughts on this is, like, one of the key things that we want to establish during such a data collection process is standardization. Like, standardize the collection process as best as possible, that there is no variation between one observer and the other, right? So I think we struggle with that. We struggle with the fact that when observers, among different observers, they mark different things based on some of their own reflexive thoughts, and as well as their understanding of what was being talked about as well. And like every other observation that we have until now looked at has very strict guidelines, because they have one specific way of doing certain things. Like, it's very technically oriented. Nutritional counseling, on the other hand, is kind of a conversation, right? Like, it's almost like talking about food, and kind of the best counselor is one who doesn't follow exactly the steps, but rather kind of makes sure that the person understands what's being conveyed in the language that is closest to the mother. So in a way, kind of understanding understanding the differences between women in terms of their ability to understand what's being said, and kind of trying to incorporate the traditional skills of counseling, like showing empathy and all that, into the process, basically. And what we felt was that these tools did not adequately capture them in a standardized manner.
Just to add to that, I think when you think of what our tools measure, we want to compare. There's two things that we can compare the work of a CHV or a CHW to. We can say, is the CHV or CHW being loyal to the program and doing everything that that he or she is trained to from the program? And then there are also, in all of these contexts, international standards. And those are, for clinical settings, those are very, very easy, and a lot of programs follow international standards, and those are, followed everywhere. For example, for ICCM, there's really the only difference you would see is maybe whatever medicine is available in a specific country or setting, but you diagnose and treat pneumonia the same way wherever there's a sick child. With nutrition, it's so much more culturally specific that it's harder to find that balance between we want to make sure that CHVs are being loyal to what the program is saying, but we also want to make sure that they're giving advice that is intrinsically good and healthy. And I think we had a hard time finding a balance between that. I think another thing that I think we struggled with, and I struggled with absolutely, is that the CHV should be adapting these messages to the context of the family. And so certain topics like the role of a father in raising a child, if a CHV knows that the father spends 11 months out of the year in a different village farming, like they're probably not going to talk about that message. And so the lack of counseling about a certain message, we can't necessarily say it's because the CHV didn't know it or forgot to do it, but it might be better that they left that out. And so there's, I think, a lot more contextual factors to account for in these nutrition settings than in other more clinical programs.
If I may comment, I think this is, it shows to me that there is more need for us to improve these tools. And at least here we have a tool. I think I gave a feedback recently on one of the surveys about if we can have an implementation strengths tool for awareness on MNCH. That makes it even more difficult, because I think nutrition, if it lacks the standard that the clinical assessments have, general awareness to change attitude and the practice is even more complicated than nutrition, because you enter into the territory of social norms and barriers to change and attitude. Eventually, it all impacts the demand and it all impacts the utilization. So what I'm trying to say that I think you have ventured into an area where there is a need. Maybe it hasn't been highlighted by others, like the clinical and facilities. But when you deal with community-based health, this is the number one you do with community, is talk in order to change. And that change is like sometimes you climb a wall and sometimes it's less that challenging because of the number of barriers. So how you implement, it's really varies widely from one country to another. But I think rather talking about all those challenges, I find the tool is still adequate. Maybe if we lower expectation, because to me, it fills a gap. So what do? Should we discard it? Or should we use it and take half of it that is useful and then try to implement it to improve it and fill further gaps? So as somebody who have been working quite a bit with community-based health, I find that there are, when it comes to evaluations, a lot of tools that follow the standards, but there is I always question my colleagues when we talk about behavior change, when it comes to gender norms and social norms. How do you know the dose of the project? Just by training people and giving them a manual? Do you say the message one time? Do you say once in a month, once in a year? Do you say it to who are the decision makers and gatekeepers in the community? I don't know the answers and whether we can have a tool that ticks and quantifies, but I think it needs more dialogue, and I'm pleased to see that where we stand today, as opposed to, why we didn't achieve it to our expectation. I will stop here.
Yeah, Louis, that's a very thoughtful response, and thank you for standing up for our tools. And just to say that our tools, as I mentioned, our tools were useful for some things, and here are some of the findings and recommendations from the analysis of the data from the tools. So there are some things that came out of it. So yeah, maybe we just do have high expectations. but if you guys are willing, I know there are only a few of us here, but I would still love to try to have a brief conversation in these little rooms to go through each of the tools. We got everybody back now. I'm just going to speak for my little room. I mean, we're just two in a room, but I have to say that that was really engaging for me and interesting. And I got a lot out of my conversation with Asrat. So I hope your experiences in your tiny little breakout rooms were interesting as well. Maybe for the sake of just going through some of the things we found in a quick time frame, maybe I can ask Asrat to take 5 minutes and talk through what he thought the strengths and weaknesses were of tool 2, the provider knowledge, the CHV knowledge tool, as well as some of the conversation that we had around standardization and about whether to do an evaluation like this going forward. So Asrat, can you comment on that, the strengths and weaknesses of that tool, and then some of the other conversation we had?
Yes, thank you so much, Melissa. Thank you for the opportunity. It was a smaller breakout session was also very encouraging, to engage, ask a question. So I found the community health workers knowledge tool very comprehensive. I think I appreciated the language. It's not too long, and the questions are very comprehensive. And then I think the design is based on the context, designed based on the program context. And then one thing is when you see the language, and if the interviewer is also maybe has a professional background, I think the tool itself can be used like on-job counseling. You can have deeper discussion on each question, and at the same time you can use it to improve the knowledge of the community health workers. The tool can be used for discussion. It's not like the survey we do with maybe beneficiaries. So we can't do interrogation. It's not like it can facilitate discussion. At the same time, we can take opportunity to teach the community health worker if you see gaps. If the interviewer has time, and if he has also background, for example, on nutrition, that is the strength. And then I have seen also like some unique questions. Like I have done lots of nutrition surveys. I have reviewed nutrition questionnaires, standard, and etc. But I haven't seen like a question which says, what are the food items like pregnant women should not take? And then there is in the list like tea, coffee, and alcohol, which is very good, because we know like tea and coffee, they are competitive inhibitors of iron absorption. So then that means the community health workers, if mention that, and then you can probe why they shouldn't take. So you can assess whether the community health worker is aware of the caffeine in tea and coffee inhibits iron absorption. If he doesn't know, then you can inform the community health worker at the time. So it's comprehensive. One gap we noticed with Melissa, like the way we can standardize a bit, like what are the types of food a pregnant woman should take. The question, for that question, I think the foods are randomly put, like you could see meat, egg, and then there is like sweet potato, which is carbohydrate, and then a mention of rice. We can categorize that based on the 7 food groups, the standard 7 food groups, and then we should try to assess whether the community health workers understand there exist those 7 food groups, and what are the minimum groups that a pregnant woman should take in order to say minimum dietary diversity is fine with that pregnant woman. So maybe we said with Melissa that could be a problem of the design, if the program is not designed like that, or if the program staff even don't know, if this knowledge is a gap among the program staff themselves, then I think that's a good area for such implementation fidelity assessment to feedback and the need on the improvement of the design. I think in general, it's finally we said, such tools maybe it's good. Evaluators, especially good to work with the technical specialist, even local one, if there are nutritionists, to sit down together and put those questions or revise the questions with someone who has a technical background along with the evaluator. I think those are some, Melissa, maybe you can add if you are.
Yeah, I'll just add one more point to Azrat's great summary of our discussion. Was we had a discussion about fidelity to the program, whether it was more important to understand whether the program, the knowledge was in line with what they were taught versus whether the knowledge was in line with current nutrition knowledge. And they're different objectives, right? I mean, the former is to try to see if they're implementing the program and with fidelity, and the latter is whether they're, and in some cases a program implemented with fidelity would further the cause to getting to impact along the impact chain. But in some cases, that if the program isn't designed in a way to that is clearly aligned with more nutritional programming, I'm not saying that if that's the case with CARES, but you may want to use more of a standard tool that assesses whether the some things that are internationally recognized, and then there's this question about how you handle it if you figure out that that you want to do a more use more standardized methods, and how that communication back with the program happens. And I think it's a sensitive conversation around whether you use that more standardized tool that may not be consistent with what the program's teaching. And I think we came out on the side of maybe that was a good way to go, and discussing with the program, how the program might be able to be connected more with some of the, to make it so that assessment would show fidelity with their program, if that makes sense. So it was a very, very interesting conversation that I think was illuminating for me, and I really appreciated it.
It makes a lot of sense. Thanks, Melissa.
I'm sure a lot of people have thoughts on that, and I think they would come out in the next section. So let me see if I can get the next tool, which is the observation tool, and that's Diwakar. And who is in your group?
Louis, please. Louis had some wonderful thoughts, so good. He's going to share.
What did I say? I thought of saying that maybe if you focus less on the counseling and the observation, if there are some external factors beyond our control, and try to find or do the analysis of the knowledge tool with the exit tool. That has, I think, limitations, because let's say that the the exit tool shows that there is no knowledge added. It doesn't mean that the implementation was not good. It could mean that the person already is knowledgeable. And you ask a question about, in the exit interview, did you learn something new? And if the answer is yes, was it a little bit, or it's a lot, something like that. So let's say if the answer is a little bit, does it mean that the implementation was not good? But what I told Diwakar, I think, is that you have started probably one of the first steps in an area where we try to evaluate something that has no clear standard like the ones compared to clinical assessments and facilities and CHWs when they administer childhood diseases. And maybe we need to do more than one iteration, but it's not going to be easy. And I think what we are trying to do, Juliana and I, and with the help of Sick Kids colleagues, with the final evaluation of Mali and the absence of a coverage survey, how do you measure the, to what extent the project reached some results? So we are looking into proxy indicators and asking CHWs about how well the implementation was done. So I see similarities in some of the questions that you're asking. That's why I think the tool could still be used. I mean, Diwakar said that there were recordings of videos sometimes. But at the end of the day, if we can maybe filter what was working and see how to increase that, as opposed to focus on what is not working, unless, what was working was only a small portion. That means that we need to redesign it from scratch. But if it was working was 40%, so it's still valuable.
Yep. And Louis did have some valid suggestions on like kind of segmenting the tool basically as well. Like right now it's quite a long tool as well, because it covers both pregnant women, 0 to 6 month olds, and 6 to 12 month old children as well. So I'm guessing that by splitting the tool into smaller portions, we probably be able to the use of the tool might be a little more easier for the observer as well. And one of the other things that I was kind of letting Louis know is, compared to most other observations, this is one of the observations where the presence of a third-party observer seems to be changing the dynamic. Like just the fact that a person is sitting there and observing you kind of makes an informal, usually informal conversation about food into a very formal, sometimes even just a one-way conversation with, where the CHV tells the woman and runs down a checklist. Like just because they're both kind of fixated on this third-party person who's observing them talk. And those were some of the things that we kind of discussed in our group as well. And yes, I think we need a little more testing on this tool and kind of more experience with it before we can kind of say conclusively what works and what should probably be kept and what should probably be kind of completely cut out of it.
Thanks, Diwakar and Louis. Do you, maybe we can go to Emily and Juliana, and maybe Cynthia was in that group, and see what their feedback is, and then we can come back to any common topics. We only have 8 more minutes left, but let's see if you can talk for 5 minutes, Emily, and Juliana and Cynthia.
Sure. I'll just briefly say we went through the exit interview tool. We had some discussion around the satisfaction questions. Juliana was also on our webinar yesterday when we talked about our Mali tool for ICCM. So we talked about our, I'll say, less than successful satisfaction questions in Mali and compared to the questions we asked around satisfaction in Mozambique. We also talked about what you can and can't say with an implementation strength and quality of care evaluation, and had a little bit of discussion as well about challenges they're currently facing in Mali with a combination of COVID and some political unrest. Juliana, I don't know if there's anything else you want to add, but I'll let you take it now.
No, thank you, Emily. I think it was helpful. I actually like your tool. So, I mean, I thought it was a good solution to collecting information and satisfaction. I think we also just briefly talk about implications of a budget, right, in the possibility to implement, and also of the current context and how it limits a lot ability we have to proceed. We actually went into touching briefly the issue of gender and also limitations of exploring gender aspects when we cannot go in open text or in more in-depth interviewing of end users, potential beneficiaries. So those are things that we discussed. And however, I mean, Emily showed me how it's been addressed in the current tool by input provided by your researcher or specialist in gender to try to bring that tool up to specs. And yeah, I think that was a discussion, and we were like, okay, so much to think about. But I actually thought it was a good tool, and I like the way you guys collected some of those tricky questions. So thank you.
Well, thank you. I think I should have said that we did think that a lot of thought was put into the exit interview tool based on Emily and her colleagues' pre-work that of course Diwakar and I were involved in designing as well. So thank you for that. And I didn't mean to disparage all of our tools. We just like perfection and didn't think that these tools were perfect yet. So appreciate that. Were there any topics in the last maybe 2 or 3 minutes of discussion that folks wanted to pick up on that other teams brought up?
Alisa, I mentioned to Diwakar if it is possible to include records review. So any implementation should have some records to measure the dose. So in the ICCM, you looked into the records of CHWs and how many cases you see for childhood diseases. The supervision system of ICCM in Mali looks into the records from a different way. They have 5 cases randomly selected and pick up a case and see if the symptoms were that written in the paper. This is reviewing paper records. What was the diagnosis, the classification, if it is correct, what was the treatment, if it's correct, and they evaluate each one. So the classification could be right, but the treatment could be wrong or vice versa, like the findings we did in the observation. Point to make that if we could add another tool on reviewing records to measure the dose and the quality of dose. So if the dose is measured to 3 segments of women, pregnant and postpartum 0 to 5 and 6 to 12. So is there should be a records keeping in the project that captures that so that one would go and evaluate it.
Yeah, that's true. We did ask them for some, I guess we did capture MUAC measurements, but just for the observations. So I think that's a great idea. The programs that are collecting enough data in a systematic enough way could be reviewed for sure to see. I think Louis, your program might be exceptional in how well you guys capture data regularly.
You know, it's not something credit that the CRC is taking. We take maybe implementing what the ministry has. Probably we are implementing it better than what the ministry is doing. But I see that if there is a system in a country, I mean, it facilitates much more. I just read recently a package by South Sudan of community-based health, and that was developed last year. And the quality of data collected, if it is implemented with the record keeping, enables such evaluation through the records as a triangulating, as an additional source of data to complement the knowledge, the exit, and the observation.
Yeah, you're right. It's more the ministry that needs to be on board with that. Okay, so with 2 minutes left, I want to mention something about this QOC ISA feedback site. So we are hoping that you will continue to pop in and give written feedback. We are planning, this is a temporary site, and it right now it's slated to be taken down on August 31st. So we'll be moving all of our materials to a new site. Then we'll send CanWaCH that information. It's not a new site. For now, it's I think gonna be moved to the Radar site we've been using, but there's a new Radar site that's being put up. So, so if you have comments for this site, please use the site between, Emily's telling me September 7th. Please input it before September 7th, and around then we'll tell you whether we've decided to pay for another month of it or whether you should go to another site to access the materials and or comment on them after that. But this has been a really great session. I've really enjoyed not having to hear myself talk and hearing your feedback and your input. And I've asked Asrat to speak, do a recording for my course based on our conversation. So I think this has been really rich for me. Is there anything anyone wants to say before we close?
I have a question. I gave some feedback on the ICCM in the survey Jessica circulated, but not on the tool itself. So would that be enough?
That's fine, Louis. I'm actually just sharing here in the chat. I'll be sending around by email as I always do. Another follow-up link. We want to make it as easy as possible for folks to provide their feedback in many different ways. So all of our JHU colleagues have access to the feedback that you provided on last session or that folks have provided on the previous sessions, and we'll have to this one. So we encourage you to share feedback however makes most sense for you. And as Melissa rightly said, we will be following up with folks to make sure that they have the recordings, but we'll also let you know what ends up happening with what site things are at. Melissa will update us, and we'll be sure to update you so that you know where you can go for more information or for more tools. And maybe the last thing that I'll just say is we know that we've heard definitely from our colleagues at Global Affairs Canada and elsewhere that this is really the time for folks to be sharing their feedback on these tools, on the practical challenges that they anticipate and possible ways to mitigate those challenges, ways in which this will really be of benefit to your work so that we can think about how they fit in to the new programming and ongoing programming that will be rolling out in the months and years ahead. So please do take the time to give your feedback on them, and also to let us know, certainly at CanWaCH, how else can we help you. So if there are additional pieces of training or orientation that are helpful to you, we want to know about that. So in your emails and of course here on the slide are the contact information for our JHU colleagues. Elizabeth wasn't with us today, but if you've been on previous sessions, you've heard her. So feel free to reach out to any of them directly. And then of course my contact information is here if you'd like to share those ideas for what additional training, support, or research would help you in your work going forward. So with that, all that remains, of course, is our final for now. Thank you, merci to everyone who participated in today's session and the past sessions. A huge thank you to our Radar colleagues for taking this time to go through these tools in depth and being so responsive and interested in receiving the feedback of different Canadian organizations. We know that you'll take it forward and fold it into the work that you're doing. And I look forward to hopefully connecting with all of you at some point in the relatively near future. And in the meantime, wishing you all the best and hope you stay safe and stay well.